Hello, hi, good day for everybody. It is a continuation in English version. The same topic which we discussed in the past video. Now the part two of that, because the second case I want to discuss also in that manner. The few kind of topics such as they required the two cases one by one. I didn't want to do in a same sitting because I was thinking that it could be the long video and couldn't be easy to handle or understand or listen for each and every person. Now I am starting this video with the same topic, which is the Chiari 1 malformation. I have the one more other patient. I just want to remind you that it's me, Dr. Mohammad Kazafi, and you are watching Mohammad Kazafi Views. I am basically a neurosurgeon, a super specialty spinal surgeon, but I am doing all kind of the general neurosurgery procedures. Now this patient is a real patient and a 37-year-old female presented with the long history of neck pain, intermittent bilateral shoulder pain, worsened with neck flexion and extension, and during coughing and or sneezing. So during coughing and sneezing, it is worsening neck pain and the backache and the shoulder pain. Associated with, she also complained of the intermittent numbness in the tip of her fingers bilaterally. The same almost the last case, but some definitely there is some difference. That's why I took that case. It will be mentioned as the lecture will proceed. On examination, there is no neurological deficit. Her past medical history is remarkable. The last patient past history was unremarkable. This patient history was remarkable, with operation as a child for scoliosis, which was corrected at the age of the 13 years, and she did not have any further problem in that regard. So considering that this case is a little different from the last case which I present in the part one, so please understand this, and we will talk about that. Magnetic resonance imaging is obtained and shown, which showing here there is a herniation of the both cerebellar tonsils through the foramen magnum 5 millimeter or more than 5 millimeter. So here the differential diagnosis, first of all, definitely it should be in mind again, because every case should consider the differential diagnosis. It will make you appropriate diagnosis, such as hydrocephalus Chiari malformation with cervical spinal cord syrinx. It could be, and my case, this is the Chiari malformation. Yeah, with the cervical spinal cord syrinx somehow, and isolated cervical spine cord syrinx following an scoliosis surgery. In my case, same thing. I consider in the differential diagnosis isolated cervical spinal cord syrinx following scoliosis surgery. Definitely the cervical spine spondylosis, tumor of the cervicomedullary junction or cervical spine. So these are our differential diagnoses, which are all correlated with each other. Or maybe you are thinking, what is the difference? Everything is same. No, actually not same. If somebody has a scoliosis and then somebody has not a scoliosis, how could be a same? If somebody has a syrinx and somebody has a no syrinx, how could be a same? If somebody has a hydrocephalus and somebody has a no hydrocephalus, how could be a same? So definitely and associated things are definitely considered separately, and because they are representing separately, you are treating separately, or sometimes in combination, but you are treating in some patient and you are not treating in that patient with that which have no problem. So in the same manner, we did the MRI, sagittal images and the axial images. The sagittal images of MRI suggestive for the A smaller posterior fossa, as I mentioned, it is a congenital problem, and it is causing significant problem. I mentioned in my last lecture. Definitely, you must listen to my last lecture also. It will help you a lot. Definitely, descended cerebellar tonsils, in the same as like before, below the level of the craniocervical junction. Secondary myelomalacia of the cervical spinal cord here. So these are the findings which I wanted to mention in front of you. Now, how we manage that case? Actually, removing the rim of the foramen magnum as we did before, and the posterior arch of the C1. This is followed by the duroplasty with or without araconite lysis, because last time I did the araconite lysis, but few people don't like to do the araconite lysis. It's up their own experience, and we respect that. We should respect that. Well, everybody has a different opinion. Simultaneously described we described our management here, and what kind of the surgical management we did or we chose. Definitely, outcome here, as I mentioned, that the expected outcome would be stabilization of the symptoms or arrested symptom progression, and there the chance of improvement in her neurological condition and a good chance of improvement of the headache and neck and shoulder pain. So I am mentioning that there is a chance of improvement in the neurological condition and the very, very good chance of improvement for the headache, neck ache and the shoulder pain, what our patient was complaining initially. Now, the possible complication usually of the procedures are there, and we definitely, in this case, I want to present you. The possible complications of the procedure include that the cerebral spinal fluid leak, subdural hygromas, wound infection, further herniation of the tonsil due to the raised intracranial pressure. It may worsen the scenario. Or the post-operative headaches and causing include the chemical meningitis from the patch or a glue what you applied during the surgery. In the same manner, possibility of the nocturnal respiratory depression. In the night, patients are suffering. There is some kind of the respiratory depression which we are telling, we are pronounced like that. This is the nocturnal respiratory depression. In the same manner, following posterior fossa manipulation, these things are usually happen or could happen. So the best management of the syrinx what? Actually, the first line of management is treating the Chiari malformation via suboccipital decompression, which I already told you. In the same manner, alternative options include adding a syringo subarachnoid shunt after a Chiari malformation in selected cases, such as the presence of the large syrinx with the significant thinning of the spinal cord tissue and obliteration of the spinal subarachnoid space, especially when combined with the syrinx-related symptom or syringo-pleural shunt we could place. Syringo-pleural shunt or syringo subarachnoid shunt, it both are the options for us. In the same manner, the pathogenesis and the theories, as I mentioned before, these are the three theories: the Gardner's hydrodynamic theory, the Williams theory, and the Ball and Dean's theory, and the Abolkar theory and the Oldfield theory. Last time I represent the three theories to you. Now in this video I want to mention all the theory, but in a very rapid manner, so you could understand what kind of theories are suggestive for the understanding of the pathophysiology of these kind of problems, such as syringomyelia associated with the Chiari 1 malformation. So here, first I am presenting you that the Gardner's hydrodynamic theory. First to recognize the frequent association of syringomyelia with Chiari 1 malformation. Third, delay in the perforation of the roof of the rhombencephalon. First, to recognize the frequent association of syringomyelia with Chiari 1 malformation. Very important. Second, delay in the perforation of the roof of the rhombencephalon, not made at the same time. Subarachnoid space does not fully open, yani again congenital problem. CSF become trapped in the ventricular system, again they are the congenital problem. The exaggerated pulsation are directed into the central canal, causing hydromyelin. Again, this is the congenital issue. So, when not developed posterior fossa properly, or the posterior fossa contents not made properly at appropriate time, definitely these kind of. So, I agree with the Gardner hydrodynamic theory. In the same manner, the Williams theory, which is suggested, this postulated and later confirmed that such an obstruction could act as a valve, and this valve allowing CSF to cross the foramen magnum rostrally more effectively than quadrantally. Rostrally more and then effectively quadrantally. First of all, it pushes behind and then down through the foramen magnum. So this theory also very much relative and regarding the understanding of the pathophysiology of the Chiari 1 malformation associated with the syrinx. This was the Williams theory. Now I am presenting you the three more theories. One theory called the third theory is called Ball and Diane theory. Ball and Diane theory suggested that activities that increase thoracic or abdominal pressure, such as cuffing or straining, cause the spinal CSF to be diverted into the spinal cord parenchyma along dilated Virchow-Robin space. So this is the theory by the Ball and the Diane, where they are suggested that this thing may cause the Chiari 1 malformation and transgression of the herniation of the cerebellar tonsils. Abulkar theory, the spinal CSF enter into the cord by the way of dorsal root entry zone. So the Abulkar theory suggested the spinal CSF enter into the cord by the way of the dorsal root entry zone, and absorption occur either by the blood vessels of the spinal gray matter or the rostral drainage through the central canal into the fourth ventricle. In the same manner, the other very much similar theory is by the Oldfield theory, and the force that pushes. It is suggested the Oldfield theory is suggestive, same like the Abulkar theory. They are telling the force that pushes the spinal subarachnoid CSF into the cord parenchyma is the CSF pulsation pressure occurring during the cardiac cycle, and this pulsation will drive CSF into the cord along the perivascular space. Other theories also, such as the intramedullary pulse pressure theory, or we can say the Treats theory, this is also very similar to these theories, and they are suggesting that the syringomyelia is caused by increased pulse pressure in the spinal cord, and that syrinx consists of extracellular fluid rather than the CSF. So, considering all these theories, we could understand the pathophysiology somehow in our understanding, which is very much we understood before, and it is just a reminder. Now again, would we expect radiological or clinical improvement to do the treatment? Yeah. How? Because expect to see improvement in clinical symptoms before radiological improvement is very much common. Radiological improvements are coming late. In the same manner, the radiological presentation is coming before the symptoms. In the same manner, the symptoms are going prior to the radiological correction. Even though radiological correction you couldn't appreciate, but the patient appreciating some improvement in their life regarding the symptoms. In the same manner, the radiological improvement and in the width of the syringe is expected within the first 3 to 6 months. Some patient 3 months, may take 6 months, but continued narrowing of the syringe may take years. So it take years means you have to follow the case after the treatment, because it may cause some issues which you have to address as a primary doctor. In the same manner, according to the Wittinge et al., the series, which was the 35 patients with syringomyelia and Chiari 1 malformation, the average diameter of the syringe preoperatively is 6.9 millimeter with a 2.1 millimeter standard deviation, whereas postoperatively it is less than 1.5 millimeter. So it means when surgery done, this 6.9 millimeter with the period of time converted into the 1.5 millimeter, it means less than 2 millimeter, which is very, very much encouraging, even though we could means accept less than 2 is okay and 1.5 is very encouraging. The median time for the syringe narrowing is 3.6 months or maximum 6 months after the Chiari 1 malformation decompression, for the Chiari 1 malformation when we decompress. What are the other different type of the Chiari malformation? Actually, if we go according to the classification, there are the 4 kinds of the Chiari malformation. Chiari 1 malformation we discussed in detail. Chiari 2 also, Chiari 3 also are there, and some people are telling Chiari 4 also, which is suggestive for the cerebellar hypoplasia. But in this topic, we are restricting ourselves just for the Chiari 1 malformation, and if needed, we will make the other video for the Chiari 2. So thank you very much. I hope you will support us, and if you find any difficulty to understand, and if you want us to, we can improve ourselves, definitely you could guide us in the comments. We will appreciate your comments with the open-heartedly. But definitely, I want to do this thing, and knowing that definitely I may make mistakes, but definitely I will appreciate your input. Thank you so much. See you in soon with the new next topic.